Okay. Well, why don't we go ahead and get started, and then we'll Dean will try to take some questions. So I'd like to thank everybody for joining us today, Met Crusaders, for our very first internet presentation. This one will be on TKIs. I'm John Halleck with Met Crusaders, and joining me today is Dr. Lee from MD Anderson, Dr. Heist from Massachusetts General, and Dr. Saltos from Moffitt Cancer Center. Before we start, just a couple of quick things. First of all, we're going to be recording this, so it will be available on the website in a few days after we edit and build a link. The presentation will last about 30 minutes with Q&A possibly at the end. There's a Q&A tab to ask your questions. We will keep the Q&A in a journal, and I'll try to edit those and provide answers in a hard copy document. And likely since it's only 30 minutes, we'll probably have to follow up with a part 2. So with that, I will start the presentation and turn it over to Dr. Lee. So let me share my screen, and share the screen. Can you see it, Dr. Lee?
Yeah, perfect.
Okay, and then you folks can tell me when you want to advance it. Dr. Lee, it's up to you.
Yeah, so John, can you put us the PowerPoint in the presentation mode? I think we can get started right away. All right, so my name is Shuning Li, one of the lung cancer doctors at MD Anderson. It's really a pleasure and also an honor today to be able to talk about, to discuss the new therapies approved for MET-altered lung cancers. Together with John, we were able to get Dr. Rebecca Hist, which is a prominent figure in the space, who had led major trials and moved forward with FDA to get approval for new therapy, who is from MGH, Mass General Hospital. We also have Dr. Andreas Santos from Moffitt Cancer Center, representing another geographically distinct area that's serving patients. Dr. Santos also work in the space together with all the providers. So hopefully today we have a overview of the newly approached therapies for MET exon 14 and MET-altered, MET-amplified lung cancer. So John, if you can move forward to the next slide. So I will start to talk a little bit about the biology first. So MET exon 14 is one of the newest oncogene driver established in lung cancer. Only a few years ago, we start to understand this a little more in lung cancer patients. So MET is a tyrosine kinase receptor. It's a regular gene expressed in normal cells. However, when there is a genetic event happen in the cells inside the lung, that leads to the exon 14 to be skipped out, so that the protein is missing the exon 14. So that leads to problems. That leads to the decrease of degradation of the MET protein, so that the proliferation of the cells will be increased. So that is the driver to make the lung normal cells into lung cancer. Those alterations are quite heterogeneous that can happen either in the beginning of the exon 14, we call that acceptor site, or at the end, we call that donor site. There is a huge variety of what type of mutation that could happen, but ultimately lead to the same biology, result in the lung cancer. Next slide. Other than exon 14 being potentially a driver for lung cancer, the same gene MET can also become a problem, become a driver by amplifying many copies of itself. So this problem is similar, where the gene, instead of not able to be degraded, the gene amplify multiple copies so that the proliferation can be driven by those additional copies that shouldn't be there in the first place. That high MET amplification can also lead to lung cancer, especially the one that's focal on the chromosome 7. That's a classic oncogene event as well. Next slide. When we look at the incidence of the MET alteration, I borrowed the slides from Dr. Heast, where we now know exon 14 occurs in about 3% of all the lung cancer patients, non-small cell lung cancer patient, and the high copy number gain or amplification of MET happen in about 1%. Since we start to learn as a field, both of those events can lead to lung cancer. Accordingly, our testing platform, for example, the commercially available tissue testing and the blood testing platforms start to be able to identify those alterations. So most of the mature platforms that we use nowadays actually cover the MET exon 14 and the MET gene amplification pretty well. Therefore, as long as we're testing, we could identify those patients and potentially give them the opportunity to be exposed to the new therapy. Next slide. In the last 3 to 5 years, I will say, we start to understand this population of patients who has the MET exon 14 driven lung cancer a little better. If I can bring your attention to the far right panel. So here we delineated the combined multiple trials information. We find out that MET exon 14 actually happened in older patient population compared to the classic driver of EGFR ALK happen in younger population. And the MET exon 14 can happen in patients, both female and male, both smoker and non-smoker, both in the lung adenocarcinoma and the lung non-adenocarcinoma, squamous and the sarcomatoid. So that actually represents a problem in that oftentimes those patients are similar to all the other lung cancer patients. Therefore, we try to convey the information or convey the message that we do want to test all the newly diagnosed cases, not picking what type of demographics we should be testing. Therefore, we can capture those patients, offer them an opportunity. I'm going to turn the conversation to Dr. Rebecca Hist, talk about the new advances that we achieved in year 2020 and year 2021 with the new therapy. And then later on, Dr. Santos will put all the new information in the context of daily practice, what we need to be aware as a patient and also as a provider. So Dr. Hist.
Great, thank you. I see one question in the chat, so maybe we just want to address that as we go on, because I think it's a little bit about biology. The question is, can a person with EGFR mutated lung cancer eventually get a MET mutation? So Dr. Lee, I don't know if you want to comment or.
Yeah, EGFR is a very mature field now. With EGFR TKI treatment, we start to see emerging resistant mechanisms, both in acquired new genetic alteration versus small cell transformation and other unknown or EMT transformation. We have established knowledge that MET amplification can be a driver for EGFR TKI resistance for sure. We have both preclinical in the cell culture data, also in the patient. There are preliminary trials showing that for EGFR mutant lung cancer patient, when they progress on EGFR TKI, if they acquire MET amplification in the tumor, those patients actually have a high chance of benefiting from double therapy, double EGFR and the MET. There are many ongoing clinical trials, I can name a few, testing if this combination ultimately can be approved to benefit patient. The question was about MET mutation. Actually, the answer is yes as well. There are case reports about EGFR patients progress on TKI acquire exactly MET exon 14 as the resistant mechanism. So we start to have data showing all those mutations can start to merge and then acting on each other and become, basically make the downstream pathway redundant. But the answer is yes, and then most likely the double therapy will help those patients.
Great, thank you. So I'm going to just turn the attention right now to some of the therapies that we have for small molecule inhibitors for MET altered lung cancer. And I'll just say that this is going to focus on primary MET, either MET exon 14 or MET amplification rather than resistance setting. But as you just heard, there's a lot of kind of exciting and data regarding combination therapy in that setting. So this past year, the FDA did approve 2 drugs for treatment of patients who have a lung cancer with MET exon 14 skipping. And those 2 drugs are capmatinib and tepotinib. And I'm going to show you some of the data regarding those 2 drugs, as well as a few others that are similar to those drugs that also do have some activity. So next slide. Crizotinib is actually a MET inhibitor. This is a drug that I think we all are very familiar with from other scenarios, including in ALK and ROS lung cancer. And crizotinib is a multi-targeted tyrosine kinase inhibitor and does hit MET. And the Profile 1001 study is the original phase 1 study where this drug was initially tested out. Initially, if you recall, it was tested as a MET inhibitor and then kind of transitioned to ALK as the field kind of shifted in that way. In any event, in this study, there was an expansion in advanced lung cancer for patients who have cancers with MET exon 14 skipping. And these patients were treated with crizotinib at the standard dose of 250 milligrams twice a day. And if you look at the next slide, it shows the waterfall plot for response in this setting. And you can see, the overall response rate is 32%, but for the vast majority of patients, they did get some shrinkage of disease, with the median PFS being over 7 months. And when you look at the type of MET alteration that actually leads to the exon 14 skipping event, it didn't look like there was a specific correlation with the exact DNA alteration that led to the exon 14 skipping. And this is consistent with findings from other studies as well. So crizotinib is a drug that has activity in this setting with a response rate in the kind of low 30s. Next slide. If you look at MET amplified, so again, this isn't EGFR mutated and then resistance of MET amplification. This is kind of pure de novo MET amplification. We have known for a while that the level of MET amplification does seem to matter in terms of how much it acts as a driver and how responsive it is. And for patients who do have high levels of MET amplification in the cancer, it does have nice activity with response rates around 40% for crizotinib in that setting. Next slide. Tepotinib is one of the drugs that is now FDA approved for treatment for MET skipping. This was the study which yielded the data for that approval. So this is an advanced lung cancer. Both tissue or blood-based testing was accepted for defining the MET skipping. And cohort A was the cohort that had the patients with MET skipping. There's another cohort for MET amplification that hasn't been reported out yet. But for the cohort A, patients were treated with tepotinib at 500 milligrams a day. And then if you look at the next slide, you can see the overall response rate is about 46% with a median PFS of over 8 months. And if you break down by treatment naive patients or previously treated patients, this was recently presented at World Lung, the response rates are stable at around 45%. So really nice benefit, a duration of response that's median around 11 months or so with a median PFS of over 8 months. This, as I mentioned before, is now FDA approved. Next slide. Capmatinib is the other drug that is currently FDA approved for MET skipping. This was the study that led to that approval. And you can see again, advanced lung cancer with MET skipping. There were multiple cohorts in this study, and they were kind of subdivided by patients who had previous treatment meaning chemotherapy or immunotherapy, not other MET-directed therapies. Versus no previous treatment, and then also by levels of MET amplification or MET skipping. And so if you look at specifically the patients who had MET skipping on the next slide, you can see on the left-hand part of that waterfall plot are those patients who had MET skipping, who previously had received some other treatment for their advanced lung cancer, whether it was chemo or immunotherapy or both. And there, the response rate was 41% with a median PFS of around 5 months. And then in people who are treatment naive, meaning no prior chemo, no prior immunotherapies, the overall response rate was 68% with a median PFS of over a year. Next slide. If you look at the kind of amplified cohorts, and here they defined amplification by gene copy number, you can see the response rates, 29% for previously treated, 40% for treatment naive. They're kind of similar to what we've seen elsewhere, where they are, where perhaps there's a little bit more robustness in the MET skipping population in terms of the response that you see. Next slide. And then finally, savolitinib is another drug that is in this space, not yet FDA approved, unlike the two others that we just talked about, but does have activity. This was a study that was presented last year at ASCO, and for patients with MET skipping who were treated with savolitinib. Next slide. A very similar kind of waterfall plot to what we saw before, response rate of 43% and a median PFS of almost 7 months. Next slide. So this is a summary of what I just showed you, and you can see the 4 different MET TKIs across the top. You know, these are relatively small numbers of patients. I'd say, as Dr. Lee mentioned, the median age here is somewhat older than some of the other genomically targeted populations. And you can see the response rates in general are pretty similar across the board, with the outlier being capmatinib in the first-line setting. That, of course, is a relatively small cohort of patients. There are only 28 patients in that cohort. And there is another expansion cohort in that study that's expected to report out to see, does that really hold up in larger numbers of people, where in that first-line setting, we're seeing kind of that high response rate. Next slide. I think the next is Dr. Saltos is going to take over.
Yes, thank you. So Dr. Heiss very nicely summarized some of these emerging drugs, a couple of which the tepotinib and that are now FDA approved for MET skipping lung cancer. And so I think some background also, you know, one of the problems of some of the older drugs before these new TKIs have been approved was that sometimes brain metastases, which are fairly common in lung cancer, unfortunately, may not have the same successful response to a therapy as metastases or tumors outside of the brain. One of the reasons for this is what's known as the blood-brain barrier. And crizotinib, which Dr. Heiss outlined, is an example of a drug that we have a number of years of experience with, not just for lung cancer patients with MET mutations, but also for, there's also an ALK mutation, which is a more common, and we have a number of years of experience where it's been observed that sometimes patients can have progression within the brain while the drug is still working in the rest of the body, because the drugs may not penetrate the blood-brain barrier to achieve a good concentration in the brain. So the part of the good, if we go to the next slide, part of the good news about the capmatinib and tepotinib is that both of these drugs appear to have better penetration into the brain through the blood-brain barrier. The clinical trials which Dr. Heiss summarized, which tested both capmatinib and tepotinib, showed very similar response rates or shrinkage of tumors in the brain to the response rate that I saw in the rest of the body, with about 50% in both cases of patients. Here's an example of a patient who, before going on capmatinib, had multiple brain tumors, which were nearly completely resolved after therapy. Next slide. We've summarized some of the effectiveness and the promise in these drugs. Now we also need to keep in mind some of the practical points, some of the side effects, and what to expect as a patient with these drugs. And so we do have a good amount of experience with the safety data that's collected from each of these clinical trials on what the side effects are. And so here I've summarized, this is a table showing what's called adverse events, or what the technical term we use for side effects for patients who were on the clinical trial with crizotinib, as the first example here. And the most common side effects that patients would experience is edema, which is what we call swelling. Oftentimes is presented as swelling in the legs or feet, legs, sometimes in the hands as well, or other areas. Patients also on crizotinib specifically can experience sort of visual disturbances. A lot of times this can manifest as flashes of light or that sort of visual symptoms. Also, gastrointestinal side effects like nausea, diarrhea, vomiting are fairly common, and fatigue as well. Fortunately, most of these side effects are low grade, and you can see what we call grade 1 or 2 side effects are those which don't necessarily necessitate stopping the drug or reducing the dose of the drug. But grade 3 and 4 side effects are ones that can be more serious. Typically, those are the cases where we might think about stopping the drug or cases where patients might need more urgent medical attention. Fortunately, those are less common. And overall, patients who took crizotinib required a reduction of their medication dose about 38% of the time on this study, and less than 10% though needed to discontinue the drug. Next slide. So capmatinib is summarized here. A very similar side effect profile. Again, these are both drugs which do inhibit MET, and so their on-target effects are fairly similar. One distinction here with capmatinib is we don't see as much of the visual side effects that you might see with crizotinib, but again, edema or swelling is fairly common, as well as some of the gastrointestinal side effects. Of note, some of the effects to watch out for with this is some patients can have their creatinine increased, and what that is a blood test that's a measure of your kidney function. Whether or not this actually means that the kidney function is impaired is not always certain, but that's something to watch out for. And also, the drug has been associated with a uncommon but potentially serious side effect of lung inflammation. And some patients can get shortness of breath either because of that or because of fluid or swelling that could occur as well. Fortunately, again, these are relatively uncommon to be serious. In most of these cases, the side effects are sort of grade 1 or grade 2 or not very serious side effects. And sort of the rate of patients who had to reduce their dose on capmatinib was overall generally a little bit lower than that with crizotinib, about 23% of patients, although again, 11% of patients did end up discontinuing the drug due to some side effect. Next slide. Tepotinib, finally, again, very similar in the profile of what side effects to expect to the capmatinib. Again, we see swelling or edema as being the most common, nausea, diarrhea, some gastrointestinal side effects being not uncommon. And then again, we see again that the blood creatinine increased, and I think pleural effusion, which is listed a little bit lower, is that possible collection of fluid on the lung. And so there's a little bit more specific data here about when side effects occurred, and they reported in the study that the average time, or the median time to which patients reported these side effects was between 3 and 11 weeks. So they don't necessarily start right away when you start the drug. It can take some time. And in fact, I think the more severe side effects sometimes manifested much later after being on the drug for a longer time. But again, the number of patients who had to reduce their dose or discontinue the dose with tepotinib was fairly similar to that with capmatinib. Next slide. So some of the practical questions about when starting these drugs. Capmatinib is prescribed, typically the recommended dose is to start at 400 milligrams twice daily. That's the FDA approved dose. It does come in 200 milligram tablets, which is usually what you'll start, and means patients take 2 pills twice a day. And this can be taken with or without food. One thing to note is the capmatinib is cleared from the body relatively quickly. The half-life, the time it takes for the drug to be 50% cleared is a little over 6 hours. Next slide. Tepotinib, on the other hand, our other FDA-approved MET inhibitor, comes in a dose that's once daily, and this is 450 milligrams as a starting dose. So patients will take 2 tablets once daily, and this should be taken with food. So a little bit different with the capmatinib. The half-life, or the time it takes to clear tepotinib, is a bit longer, which explains the once daily dosing. And it's about 32 hours for that. Next slide. So just some general things to think about when, if your doctor is recommending one of these capmatinib or tepotinib drugs. So laboratory testing, blood work, including liver function tests, should be checked before and while you're on therapy. And also, while you're on therapy, make sure you let your oncologist know if you develop any shortness of breath or respiratory symptoms, because again, these are rare, but potentially serious side effects that can occur. The swelling, which is one of the more common side effects, I typically recommend patients to wear compression stockings, elevate your legs as much as possible. A lot of these measures are some of the easiest to do and better results interventions that we can try. Diuretics or fluid pills can sometimes be attempted, but they're not always very helpful. In some cases, patients can talk to their doctor about whether or not the dose of drug could be adjusted for those less common but more severe cases. But most of the time, it's mild. And also be aware of any potential drug interactions, including grapefruit. So not just drug interactions, but also these drugs are cleared through the liver through specific enzymes called cytochrome P450 enzymes, and grapefruit can sometimes inhibit the clearance of some of these drugs. Next slide. And so this is just a summary of the disclosures of our involvement with research with various companies. I don't know if there's another slide, but I think we can move on to our Q&A period.
Okay, so we only have actually one question in Q&A. I guess I'll give everybody a little bit of time to ask a question if they would. And any of the panelists have any kind of additional comments or thoughts?
I just want to add that today's session, we covered the 3 to 4 approved or widely used or have the most mature data. But the field is moving so quickly that we have a lot of new drugs, not actually limited to small molecule oral inhibitors. I think as a community, we're developing even better TKI, we're developing antibodies, we're developing ADC, and like completely novel approach also coming up. I just want to be sure that the field is moving quickly. Today, we can only talk about what we have accomplished, and then there are a lot more coming.
Okay. Dr. Hayes, Dr. Saltos, any comments?
I was going to say, yeah, the fact that, less than a year ago, we had no approved specific MET drugs, and now we have 2 is a testament to that, I think.
Dr. Hayes, any comments?
There are some questions in the chat, so.
All right, great. If you have show progression on one of the TKIs for MET, any chance for another might work? Does anybody like to take that one?
We did actually just publish a study of looking at capmatinib after prior MET TKIs. So this was, in all of the data that I had shown, none of the studies allowed prior MET therapies. And so we had run a small study looking at the activity of capmatinib after other MET TKIs. It was predominantly crizotinib, just because of what the practice patterns were at the time when we were running the study. The overall objective response rate was about 10%, which is obviously lower than what we would hope for. There were some people who had stabilization of disease I would say that what I saw in that study was that if there was progression in the brain on crizotinib, capmatinib was pretty effective. And I think I would expect similar results from tepotinib, knowing both of their CNS activity. But immediately after another type 1 MET inhibitor, it had limited effectiveness. I think if there's a long period of time where MET inhibition has not been part of the treatment regimen, you may get a re-response. So I think kind of immediate sequencing probably doesn't make a lot of sense to do. I do think we do know that based on resistance, which we didn't talk about very much, but there are resistance mechanisms to the type 1 inhibitors where there are some of the type 2 inhibitors that are expected to have activity. So if there are some specific mutations seen, a type 2 inhibitor like cabozantinib, for example, could be a consideration.
Dr. Saltos, Dr. Lee, any comments?
Yeah, I agree with Rebecca's comments, and then she also I read that paper, so it's nice to start to have data. In terms of chemical structure, they all belong to the so-called type 1 inhibitor, so that to a certain degree, it's not surprising that if the tumor, the biology is really not being controlled by type 1 inhibitor, unlikely another type 1 will render a new big benefit. So biology also support that results as well. What I want to say is we're still learning the resistance mechanism. If the tumor progress, I do think the profiling, trying to identify resistant drivers is important. Not only for type 2 inhibitor, but potential other bypass mechanism as well. So we're profiling at the progression and then just open your mind, talk about all other possibilities, including trials, chemo, IO.
Right. I think that that also ties nicely into, I think there's a question about what next after if capmatinib fails. And I think similar to your point, similar to the way we also think about other oncogene-driven lung cancers, if a targeted therapy with a TKI fails, we often recommend sequencing of the genome again of the cancer to sort of see what the reason for resistance or what the reason for failure was. Again, sometimes we find that there isn't anything specific that opens up a new door for a new therapy that's outside the box. But sometimes we do find another mutation. I think earlier in the program we talked about sometimes a patient with an EGFR mutation can acquire a MET mutation. And it hasn't been, as to my knowledge, as quite as well characterized for MET as it's been EGFR. But if there's a resistance gene mutation that matches with another oral therapy, there's always the possibility for something outside the box. And certainly, if not, to Dr. Lee's point, oftentimes a clinical trial might be available, and that's something to inquire about if there's anything that a patient might be eligible for.
Yeah, and just to expand on that, in addition to the secondary mutations in MET, other pathways that have been activated at resistance include MAP kinase and ERBB pathways. And so the importance, as Dr. Saltos was saying, of kind of biopsying and understanding what's going on, that can direct you towards what general pathways you want to be inhibiting with your next line of therapy. And also, as Dr. Lee was saying, there are antibodies against MET, bispecific antibodies and antibody drug conjugates that can also be considered after TKIs. And I've certainly seen those drugs do have some activity after TKI as well. So it would be definitely something I would think about.
Okay, there's another question here about TKIs together with immunotherapy checkpoints. I see a lot of trials where they're combining TKIs with other drugs.
Yeah, so there are trials. There is actually an ongoing trial in patients with MET skipping lung cancers of capmatinib, for example, with the PDR001, which is a PD-1 inhibitor. I would say that it's a little early to know. In other targets, there was concern with combining with immunotherapies because of heightened tox, and I think that's something that we don't quite know yet. There's some data from previous studies where it looked like there was reasonable combinations with immunotherapy without heightened tox, but I think we really need more people to kind of know exactly what that's going to look like. But that's being actively studied now. I don't think we have the answer to that yet.
Okay.
I think some of us, I showed it in the earlier slide, the exon 14 patients, they're oftentimes had a prior smoking history. The tumor tend to have a higher PD-L1 compared to EGFR and ALK patients. So even the monotherapy immunotherapy of clinical trial we all have anecdotal experience of those patient, exon 14 patient with high PD-L1 actually benefited from the immunotherapy. So I think Dr. Hest was talking about that combination trial. To me, I think from the efficacy standpoint, from the biology standpoint, to me, it's very promising because for those patients, if a subgroup of the tumor cells respond to TKI and then the immune component can keep attacking the tumor, that potentially can not only leads to deeper response, but also longer response. It's early, so we're all looking forward to see at least pass the initial safety and then see if we really have the efficacy benefit to pan out. But I think it's a very promising, very interesting combination idea.
Yeah. Okay. Another question about the TKIs in conjunction with Tagrisso.
So I think this is also being investigated in clinical trials. I think, as mentioned, I'm aware of at least a couple of clinical trials, specifically in that EGFR patients who start with an EGFR mutation and require a MET amplification, looking at the combination of an EGFR Tagrisso therapy with either tepotinib or others. I think outside of these clinical trials, for certain situations, this could be considered, although it would not be, it would be off-label use to combine them. It remains kind of investigational at this point.
Okay. Moved on. I think there was a question about MET14 skipping and amplification 15 times. They have a PCR after pneumonia only treated with crizotinib. And they stop it. I guess the nodules come back. And the question, I guess, is they also saw pleural effusion. I'm not sure exactly the question there. Doctors, you can see the.
So, MET skipping and MET amplification don't always go hand in hand, but can be seen together. So they're kind of overlapping. So not everyone whose cancer has MET skipping will that same cancer also have MET amplification, but occasionally they will both be together. So that is seen. The question about nodules coming back after being off crizotinib, I don't know. I think the question of when to treat and when to start treatment, depending on what's seen on the scans, is always something you would make with your oncologist. Depends what the nodules look like, how suspicious they look, and things like that. But CRIZ is an option. Tepotinib would be an option. Imatinib would be an option. A clinical trial would be an option as well. But I think the question of when to start and which one to start is something that really kind of needs a discussion with the oncologist who's actually treating you and review the scans, because nodules are a little bit unclear exactly what they are. So if it's a nodule that we think is just an inflammatory nodule versus a nodule that we think is a sign of cancer there, we would kind of address those differently.
Okay. I don't see any more questions in the Q&A, but there was a couple in the chat. One said, can ALK rearrangement become MET? I don't know if it can transform. It's you could acquire something additional.
Yeah, so we don't really think of ALK transforming into MET, but certainly there are now also reports of people who have ALK rearranged lung cancers who then have MET amplification as an acquired resistance. And it does look like MET amplification in general kind of comes up pretty recurrently as an acquired resistance mechanism across multiple different kind of oncogenic driver types.
Okay. Any other comments on that?
Yeah, I agree because I think MET amplification can serve as a resistant mechanism to the EGFR patient in the incidence about 15%. And interestingly, most recent reports show that for ALK rearranged tumor at the time of resistant, MET amplification was also at 15%. And for RET fusion cases, even with the newest RET inhibitor, the MET amplification also 15% as the resistant mechanism. So almost like MET can be a conversed resistant mechanism. We have, as a field, have case reports showing that for those acquired secondary mutation, the double therapy is truly needed. Some of the newer drug, the safety is not completely clear, but I think talk to your treating oncologist, and then it may be reasonable to try the double therapy and starting with maybe lower dose and watch very closely. But I think the biology supports the potential of using the double in either EGFR or ALK or RET. I think the biology is very similar across the board.
So here, there's a question that was asked. We have in the MET community patients that already have ALK and RET and have a MET component too that are on both an ALK and a inhibitor for MET, and that doesn't work. Kind of what's next? That's gets pretty complicated.
So, I do think that would be a situation where you would want to get more information, either with a tumor biopsy or a liquid biopsy. I think when we're thinking about what's the next thing to do, we're trying to figure out what's going on biologically with the tumor at that point. And getting information about whatever you can from either tumor or liquid about the tumor genetics would be very helpful, because a priori it's hard to say, is there another pathway, or is there a secondary mutation within ALK or RET, for example, or what else is going on, what's driving it, and you want to kind of then go to the treatment that you think is driving that resistance. So there, I think the importance of kind of understanding the resistance better would be critical.
Okay, why don't we do one last question, and then I've taken enough of your time. You need to get back to patients. The question was, if you become immune to one of the inhibitors and then go off to another treatment regime, can you come back to the inhibitor and will it work again?
So I'll say I've seen the most success in terms of the same inhibitor working again when there's been a period of time where you're not treating or hitting that target. So in the study that we had done of capmatinib, for example, after prior CRIS, the best responses were when there was a long period of time with that MET-directed therapy. And I think of that, I'm kind of drawing a parallel there between MET inhibitors in general, but I think in general, if you have a long period of time where it's been MET-directed therapy, for example, with chemotherapy or something like that, then coming back with MET-directed therapy may be able to give you a response. I think if there's been a sequence of multiple MET inhibitors after another, I'd be a little bit more worried about will the return to another MET inhibitor actually have activity? And I think getting biopsy data that then would be very helpful.
So maybe if you were on a MET inhibitor and then you went on an antibody conjugate and then you came back to a MET inhibitor.
Yeah, I mean, I think the general idea is that selective pressure on the tumor is important in terms of kind of what clones of tumor are proliferating. And so when you don't have MET-directed selective pressure, then returning to MET-directed therapy, in my mind, has the highest chance of getting another response.
Okay. All right. Well, I'd like to thank everybody for their time, and maybe we can put something together on resistance mechanisms and maybe some of the drugs that are in trial that show some promise. But today, I thank you very much for your wisdom and your participation, and hopefully we can get together soon. So thank you so much. And thank you for everybody that visited today.
Thank
Yeah,
you.
thank you, John.
Thank
Bye.
Thank you.
everybody.
Bye-bye.